Hello, and welcome to the Vermont Blueprint for Health, Working Together for Better Care webcast. My name is Janice Ginevro. I'm from the Agency for Healthcare Research and Quality, and I have the pleasure of introducing this webcast to you today. First, I'd like to give you a little background on the program sponsoring today's event. The Prevention and Chronic Care Program is part of the Center for Primary Care, Prevention, and Clinical Partnerships within the Agency for Healthcare Research and Quality, a federal agency that is part of the Department of Health and Human Services. The mission of the Prevention and Chronic Care Program is to improve the quality, safety, efficiency, and effectiveness of the delivery of evidence-based preventive services and chronic care services in ambulatory care settings. Today's webcast aligns with our strategic goals as noted on this slide. It's part of a larger effort to learn about and share best practices in the integration of primary care, public health, and community services to improve preventive and chronic care services, with the goals of improving the health of individuals and the population as a whole. We hope that you will explore AHRQ's Prevention and Chronic Care web pages. We'll provide links to additional information at the end of the presentations. We have a unique format for the webcast today. The agenda includes a video presentation interspersed with a panel discussion from those involved in the Blueprint for Health program in Vermont. The video highlights the successful linkages among public health, primary care, and community services to provide comprehensive coordinated care to the citizens of the state of Vermont to improve health outcomes and reduce costs. The video will be shown in 3 segments. Then, in between each video clip, we will join a panel discussion where we'll hear more from those implementing the program in Vermont. While we will not have time for a live question and answer session, we encourage you to submit any questions or comments via the chat feature, and we can follow up with you later. To do so, you will click on the Chat tab to open up a chat window. Select Host from the Send To dropdown to ensure that we receive all comments and questions. Type your message in the chat box at the bottom of the chat window and click Send. You may also chat with other participants during this event. Now that we've taken care of the introduction to the event and some housekeeping, let's watch the first video segment.
Vermont's Blueprint for Health is a statewide public-private initiative that seeks to provide the incentives and the infrastructure to support the delivery of coordinated, high-quality health services.
Okay, so I saw you, I think, about a month ago.
The Blueprint is hoping to help Vermont achieve the triple aims. And the triple aims really include improving the health of the population, improving control over healthcare costs, and improving the patient's experience of care.
To accomplish these goals, the Blueprint creates a comprehensive approach that addresses some of the most fundamental components and drivers of healthcare.
The design principles are to have high-quality primary care for all citizens, to have the support, the multidisciplinary type of support that many citizens need, to really link community services with healthcare, to take away the silos, and to really bridge more comprehensive health and human services.
The first step was to make fundamental changes to the delivery of primary care.
When you look at the primary care physician's schedule any given day, they have usually a 10 to 15-minute block to see a patient. When you're dealing with someone with often multiple chronic diseases, sometimes financial issues, housing issues, to think that you can handle that in a 15-minute visit is ridiculous.
Prior to the Blueprint, what our doctors would talk about was that doorknob moment. When they were just about to leave the room, they were really afraid to say to the patient, is there anything else I can help you with? Because they didn't have the time to help, they didn't have the resources to help.
Primary care providers, when asked to identify one of the gaping needs that they have, consistently talk about the need for more access to mental health services, substance abuse treatment services, and also assistance with helping to change the health behaviors of the patients that they see.
John, how are you? So John came to me as a new patient And I remember, because this happens all the time with patients, that he says he has a touch of diabetes or may have a little sugar, but looking back in the record, it seemed like he did have diabetes. So at the very first visit, I drew some labs, one of which was the hemoglobin A1C. It came back at 8.5.
Dr. Hebert was telling me, I'm going to have to put you on this medication called metformin, and then you might have to take insulin, and we got to kind of make a decision here.
John wanted to avoid being put on diabetes medication, but he had never been successful at making lifestyle changes before.
That's me with like 3 extra chins. I probably weighed about 250 to 260 pounds. I would go through spurts where I would be able to lose weight. That would be by diet and cutting back on stuff. I've lost 20 pounds, and all of a sudden, boom. In 2 months, that 20 pounds is back on, and maybe it's 30.
Fortunately for John, the Blueprint model provides doctors with access to multidisciplinary community health teams to provide the necessary health education and supports that patients need.
We use 3 different screenings. We use one for anxiety, one for depression, and one for alcohol use. So when I first met with John, it became apparent that he was suffering from some depression and was using alcohol more than a normal amount.
I hurt my back working in produce, and basically I have 3 herniated discs. I have degenerative disc disease, and I am on full-time disability.
We definitely talked a lot about how his depression and his alcohol use was affecting his nutrition, quality of life, and his diabetes. So about a piece of bread this size is what we would consider 1 carbohydrate serving.
She got me involved in making the decision instead of just telling me, you have to do this. Emily's always like, do you think you could get yourself to the pool 2 days a week? Do you think you might be able to eat wheat bread instead of white bread, which is so much better for you?
After our first meeting, John decided he was going to start focusing on identifying his carbohydrate portions, and he also resolved to get back into the pool at least twice a week for 20 minutes.
I was probably not sure that John would make those changes. You know, he's a middle-aged man and hasn't made too many changes for most of his life. I didn't know if he'd be able to make those.
What she's done is helped me organize, to really come up with a plan and made it more well-rounded and made it easier to follow.
I think once he started working with the dietitian and making a few changes, he felt a lot better too.
I think I've dropped somewhere between 36 and 40 pounds. I'm going to the pool on the average 6 out of 7 days a week.
I'm getting a lot of feedback, just positive feedback about how you look great. I don't feel like I'm done yet. I'd like to lose another 20 pounds on top of the about 40 that I've lost. I'm very happy. I feel healthy.
And that's what really keeps people going, is knowing that they have the confidence and the abilities to keep doing it every day.
Becoming involved with the community health team, the Blueprint for Health, has definitely benefited my practice over the last year that we've done it, and I think it's better for patient care.
I'd like to welcome our audience and thank you all for joining us today. I'd also like to thank AHRQ for doing this and helping us to tell the story of how the Blueprint program is being built in Vermont, in communities around Vermont, and how it may be extendable to other areas around the country. My name is Craig Jones. I'm the director of the Vermont Blueprint for Health, and I'm joined today by a panel of the experts who really are the people that are building this program in their communities. So let me introduce you to the panel, and we'll get started with the discussion. On my left is Laurel Ruggles, who's the Blueprint Program Manager in the St. Johnsbury area. And next to Laurel is Pam Smart, who runs the community health team in the St. Johnsbury area. Next to Pam is Penrose Jackson, who runs community health improvement for Fletcher Allen, and that's the organization that is building the program in the Burlington area in Vermont. And next to Penrose is Pam Farnham, who runs the community health team in the Burlington area. So let me welcome you all, and again, thanks for joining us today for this discussion. Let's start off talking a little bit more about how this program affects patients. One of the most important aspects seems to be the holistic services, how we're helping people meet the basic needs of life. It's tough to engage in healthcare without having the basic needs of life. So let me turn to the folks who are running the community health team, and Pam, let's start with you and
Sure.
ask for examples.
Thanks, Craig. Well, I think the big difference really for John in this example was we really helped him define the barriers to, improving his health and decide on how best to approach those. For him, alcohol was really something that he was using to control his depression or treat his depression. So when we helped him understand that, it really made a big difference for him, and he was able to move forward, and you saw the success he's had.
Thank you.
And for us, we've just absolutely loved having a chance to provide the holistic services for folks, addressing the psychosocial needs that they need to take care of so they can focus on themselves. We found many people couldn't focus on their medical condition until we met the other things, like housing and access to health care and insurance. And one of our referrals actually came from one of the school nurses, and it was a child that had been out of school for 4 or 5 days. We're actually the first call from the school nurses when they find a family that may have some needs. And when we went and called and then went to visit, we found that Dad had recently lost his job. Mom, no health insurance, no access to health care. Very worried about going to the emergency room and incurring another bill. And the child had been sick, and she was trying to treat her with home remedies, but she really needed care. So a call to our pediatric practice, the care coordinator got the child in. We were able to come up with some funding to get her medication. 48 hours later, the child's back in school.
It's an amazing story. So just to maybe help understand it a little more, what are some of the types of people that you need on the team, some of the disciplines that you found to be most important in building your health teams, your community health teams?
Well, we knew that we already had some of our positions in place, and so when we had a chance to grow what we had and really be able to provide services for folks, we were eager to do that. We have behavioral health therapists in each of our practices. We have care coordinators in each of our practices, and we have community health outreach workers, which makes us a little bit unique, that meet with folks on a regular basis. People are referred in either by providers or by members of the community or people themselves, where the health outreach workers can actually support what people want to have happen and what they need to have happen. We also have a health educator that works with folks. And so that's our core team, and myself, who gets to play with everyone and help lead the team. And so that's basically our core team.
And Pam?
And I think one of the things that we've been really excited about is the opportunity to mold this whole plan really to meet the needs of the community. So in our service areas is a much larger, more urban area. We really don't have as much of the embedded model as St. Johnsbury does. We have community-based folks that actually go to clinics and see patients as needed. So our teams have nurses, social workers, licensed clinical social workers, registered dietitians, and health coaches, similar to your health outreach workers. And we also have a fitness component. So we've added our local YMCA to really help people with that dimension of fitness and how that really fits into the overall health of folks.
Yeah. One of the other aspects that has been so interesting to watch is the development of this teamness in each of the communities. People that may traditionally not have worked together now are working together in different ways. And can you talk about how you nurtured the relationships that you need to develop this teamness in each of the communities? And particularly what some of the barriers were to developing those relationships, and then how you overcame them?
Well, I can certainly start. I think at one of our pilot sites, it is the largest internal medicine site in the state, with 12 providers, 12 very different people. When we started in that practice, we had a couple of physicians that really loved the model, bought in, and then we had some real naysayers. So really, I think being at the practice, continuing to offer support to patients, and really once a patient comes back to a provider and says how helpful the team was, or the physician sees an improvement in a lab value, et cetera, it really helps to bring that multidisciplinary team and have the patient and the provider be a part of that team. I think prior to that, it was kind of we are the team and they're the extras, and now we really are a team.
And our team started with our core team, but it has grown so that we have a larger community team that meets once a month also. And there's approximately 40 people that come to that team meeting. We have found we don't want to duplicate any services, and that once people realized that we're here to partner, not to replace what you're doing, then that barrier was broken. And we work in a collaborative model where everybody's a phone call or a referral away. No longer do patients have to go to 4 or 5 different places. Whatever that person needs, with the permission of that person, we call a team meeting in to meet with them. And patients are loving that. They don't even know they're part of a team, they just know who's helping them. And we're avoiding crisis because they're accessing someone on the team sooner than running into crisis. So it's been a really wonderful model. And once people knew we're in it together, we're not looking to compete, the team became trusting and the relationship formed. Mm-hmm.
Trust relationships are so important, but let's go ahead and look ahead and learn more about the foundation of the blueprint, what really makes up the model, and again, more about how it's being built in each of the communities.
The Blueprint for Health calls for the creation of patient-centered medical homes, supported by community health teams, working in conjunction with public health services to improve the health of both individuals and populations.
So what a patient-centered medical home really is high-quality primary care, high-quality preventive care, great access for its patients. Do they really have the ability to get in and get the health care they need when they need it? Is the care they get really well coordinated? Do they communicate well with the families and the patients that come to them? Do they follow up closely? Do they track things carefully in electronic systems? Do they manage a population by pulling reports and looking at all the people who are missing tests or need assessments or who haven't been in?
The blueprint changes the incentive structure for healthcare providers. All of the payers, including insurance companies, Medicare, and Medicaid, pay into a system to provide incentives for practitioners and to fund the community health teams that support those providers. Rather than being rewarded for volume, patient-centered medical homes are reimbursed based on how well they are evaluated according to national standards.
Every practice in the blueprint in Vermont is scored against these standards by a team from the University of Vermont. That then makes them eligible for the payment reforms that help support that high-quality care.
The patient-centered medical homes are supported by community health teams.
So the community health team has nurses, social workers, registered dietitians, health coaches, and other supports. We looked at our resources in terms both of our community resources and also what the clinics had and needed. And then we said, what does our community have in need? And then started to develop it based on that.
Sometimes, team members are embedded in primary care practices.
Hey, my name's Chelsea. I'm the chronic care coordinator. Nice to meet you. You too, Jessica.
We have the care coordinators and the behavioral health specialists. Most of them are nurses as well, and their role is different from the typical office nurse. The care coordinators have the time to sit and talk with the patient and find out what else is going on in their lives.
I really don't want to go on the medicine, so if you really feel like this would help, I feel very confident.
In addition to having community health team members embedded in patient-centered medical homes, team members may also be available in the community. These community health workers assist patients with health education and non-medical social supports that may affect their ability to receive health care.
Yeah, I may lose the health insurance I have at my job. They cut me back.
Yeah, that's what I understood.
I'm back to part-time now, and my wife's really worried. She's disabled, and it may really affect her not to have the insurance.
Okay. You know what we could do? We could apply for Social Security disability if you wanted to.
We've found that by working together, partnering, and wrapping people with services, we're preventing crisis, where you really do get a chance to look at what's going on with folks, because they can't concentrate on their illness until the rest of their life is stable.
We really look at it as a partnership with the providers, the doctors and nurses in the medical home. We meet regularly with them. We communicate via the electronic health record. They send us referrals on their patients that they think could benefit from help with any number of issues.
Many communities also take advantage of community health team extenders to support more targeted subpopulations. The Support and Services at Home, or SASH program, helps older adults to live and age safely in their own homes.
Welcome home, Audrey.
Thank you.
How are you doing?
With the SASH program, I think they filled a need. I had a fractured ankle, which arthritis is set into now, and I have Parkinson's. And there's a lot of stuff available here. I didn't have the courage to go there and see until I got into this program.
The Blueprint for Health also supports Healthier Living Workshops, a series of classes that empower participants to better cope with their symptoms through peer support and skill-building exercises.
Gardening is completely foreign to me, but I decided that I would do 1 hour every other day as a realistic goal, 2 to 3 times a week. And I haven't quite gotten it together to do it every other day.
And that's part of the self-management skills, that sometimes life gets in the way, doesn't it? We might have the best plan.
The Blueprint's support for local innovation is clearly evident in the functional community health team.
We have a community really rich in resources, not a lot of money, not a lot of funding, but a lot of people who really care.
This broad group includes local community health and human services programs, including nonprofit organizations and public health programs.
I'm Karen Stewart. I'm the acting district director for the St. Johnsbury Vermont Department of Health office, and I'm also...
By coordinating with this larger group, the core community health team can leverage enormous resources to help provide expanded services for their patients.
And so one of our interests is to provide some kind of a program for high school students who are already engaged in drug and alcohol use.
They can also work with this larger group to support the development of new services in their community.
So as we looked at St. Johnsbury, thinking, what do we have around here just for teens where they could come and feel safe and talk about their issues and try to work through some of those. And we couldn't really think of anything that we specifically have, so we thought, well, why don't we see if we can start something?
The Blueprint connects patient-centered medical homes and multidisciplinary community health teams with public health resources and health IT infrastructure.
The role of public health in the Blueprint for Health has been a really important one, and it brings that broader point of view about how we think about the health of the whole population and well beyond the scope of just primary care.
This is the kind of work that is really starting to get clinicians and public health officials talking across the board and talking together about how their work can be beneficial each to the other. I'm now hearing clinicians talk about the social determinants of health, and I never would have heard that 10 years ago. And I'm hearing people in the public health arenas talk about the value of the clinical care and how public health needs to support it.
The Blueprint model encourages healthcare providers to use electronic medical records. The Department of Vermont Health Access is building the IT infrastructure needed to collect health information from the electronic medical records of healthcare providers into a health information exchange. This exchange can then interface with a central clinical registry, which can provide data back to healthcare providers, community health teams, and public health policymakers. This data can enable visit planning, better care coordination, and more accurate reporting.
The importance of the Central Clinical Registry and the health information infrastructure that we're talking about with the Blueprint can't be overstated in terms of improving care and also helping us understand where are the next things that we need to focus on as a system.
The real idea here to help achieve the Institute of Medicine's vision for a learning health system is that people, just by going to work every day, electronic medical records capture information. A multi-payer claims database is capturing information about the quality of healthcare and healthcare expenditures. They're able to capture very important information, and we needed to bring that information together into systems where it could turn into knowledge.
I can give you an example. The care coordinators located in the medical homes all have access to their patients who were seen in this hospital. So they get those lists automatically every morning. And then they can see who of their patients were in the hospital and they can follow up. And that's just seamless. It just happens.
And that knowledge then is available back to the practices, back to the communities, so they can continuously see how they're doing and set goals and try and improve against that information. That's a learning health system.
Welcome back.
Let's continue our discussion and learn more about how the program's been built in each of the communities. Let's start off by talking about how you all were able to get people to work together in new ways. Traditionally, so many of the people that are involved in your programs worked independently, and patients really are left to navigate on their own. Breaking down those barriers, getting people to work as though they're part of a system, even though they weren't, is pretty novel. So at a system level, how is this really different for you? Laurel, let's start with you.
Well, I think we had to start really with the primary care office and get them to start working as a team. I mean, I think back to 10, 11, 12 years ago, where a lot of the primary care offices, I think they felt like they just needed to get through the day. They would talk about how they were, describe themselves as they were taking care of sick people. And the reimbursement mechanism made it so that they had to take care of as many sick people during the day as they can. They had to get a lot of people in. So they had to start thinking about themselves as a team, and not just the doctor and the nurse team, but what can that person who's scheduling the appointment for the person with diabetes, how can their role change to make this whole practice work more efficient? And when that person with diabetes gets checked in, what's the role of that receptionist that checks them in? So it started there, where they started thinking of themselves as a team, even before we had a formal community health team. Then when we had an opportunity to pull in and add to and have an actual formal community health team, they were already thinking in terms of, we need to work as a team, what else do we need to have as part of our team? And then it was sort of natural to expand that out from the primary care office into the rest of the medical providers, not just specialists, but registered dietitians, physical therapists, the eye doctor, and also the mental health providers in the community. So it started in primary care and then made its natural progression out.
Penrose, how about for you?
It's the same. It's the piloting and allowing for the evolution. We started with two practices, one a single provider, kind of more the typical Vermont practice, and also, by Vermont standards, a large adult internal medicine practice. We owned the internal medicine practice. We did not own the other one. So we started working in both those environments around what is it like to be a team. And it was fascinating to watch the exercises that people would actually go through, and that when you started off and you'd assemble everybody, you'd have the scheduler and the nurse and the doctor and a few others. Their first default was always to defer to the doctor. And that as the process developed, you were seeing the interplay of people change. And by forcing them things like, you're going to lead the meeting this time, it's not the doctor, was very, very helpful. Because no one had ever done it before. And that's the real challenge that we faced. And we also, I think both us and both at Fletcher Allen, also at St. Johnsbury, building based on the people you knew. We grew the team organically. We started off with people that we'd already worked with, that we knew their skills and interests. We trusted them. And then we worked with them to build the team that would best serve both the patients and the providers.
So building on this theme a little more, the change at a systems level, one of the things that has always stood out is how important it is to have strong leadership, good leadership, get all the right stakeholders together, and intuitively we all understand that. In our case, we've been able to get all the insurers together, have payment reforms that go across all the insurers to support these teams in the medical homes. And that part has taken place. But one of the most striking changes is really the cultural change that emerges in a community as trust develops, which was mentioned earlier. So let me turn again to you to describe, if you could, describe how you see that culture change emerge over time. How long does it take? What should people expect if they try and form these teams? And let me start with you, Cam.
I think that as Laurel referenced, it started small. It can take time. I think you have to understand that and give time for the relationship building to happen as the team grows. We're 3 years into the community health team, almost 4 now, and the trust is there. And I think knowing that supplementing each other, we can do more than any of us could do alone, has helped us with satisfaction of our positions and of seeing people move forward. Whether it's now with self-management, taking care of their their illnesses, people are saying, what do you want to have happen? The culture of what do you want to have happen, not, well, I told you to do. So it's a cultural shift that's come slowly, but very exciting to see happen. People are finding their voice. They know they can partner with their provider. They don't just sit there anymore and be told what to do. And the providers are loving that. They're loving that people are being vested in saying, well, that's not going to work for me. Is there another decision? Is there another treatment plan? Or maybe I can't afford that. So it takes time. And it's slow, but when I reflect, really major things have happened in the last few years.
Let me turn to Penrose and Pam. And in Burlington and for Fletcher Allen, this has been maybe a different type of challenge to see this teamness emerge. And again, even with strong leadership and the payment reforms, in one sense, the payment reforms offer the opportunity. But how did you get the culture change to occur? And really, how long does it take? What do you see happen as the culture change occurs?
Well, it's still ongoing. It hasn't totally happened, but again, it was really on a case-by-case, one-by-one basis, and we tried the cookie cutter. Oh, invite everyone to a dinner, and you can introduce them to the concept, and they'll all leave the dinner saying, "Yes, sign me up." It was very hard getting people there, and because we hadn't worked with them in the past, they weren't, raising their hand immediately, and we needed to nurture those relationships on a one-on-one basis. And before we even go in, Pam and her team go in and actually meet with the provider at the practice site. Maybe you should describe that.
Sure. We try to meet with the leadership, lead physician, supervisor, and anyone else that's interested, and really talk about what they feel their barriers are to really giving excellent patient care, and how might we be able to help fill those gaps. And we've done a number of pilots. Psychiatry is a huge issue in Vermont, as probably elsewhere. And we have a pilot going on that really puts a psychiatrist in the primary care office to see patients, to talk with providers about medication, therapy, etc. So that's been a real plus, and that really helped that clinic particularly say that's what we defined as one of our biggest needs, and you helped us fill that need. So that's really, a lot of listening. I think we sit and we listen a lot. We really help them understand that we really are there to really help with whatever their needs are. And I have a great example of, we have meetings, multidisciplinary team meetings with a group of providers around their patients. And at a meeting recently, one of the providers, who really was kind of one of those, well, I'll stand back and see how it all plays out, said as she was leaving the meeting, she had offered up a really complex case and really wanted to hear what the social worker could bring to that, and what the dietitian and the nurse, etc. And she said, this is exactly why we do this work. This is why we have a community health team, because now I really have a path for this patient that I was at a dead end. I didn't know what to do, nor did the patient. So she was really at a point where even thinking about trying to see if there was another provider that might be a better match for this patient than she was. And she left that meeting feeling like she really had a path now to move forward. So that's a really nice thing to see.
The other thing, Craig, that has helped is that the administration from day one has felt the community is what makes the hospital run, not the hospital directing the community. So encouraging and welcoming people to be part of the community health team process. We actually rotate facilitation with the field director of the Agency of Human Services, and also with the person from United Way, that they lead the community health team meetings. So it doesn't look like it's us telling people, because we're not. We want to meet your needs. How can we work together? So I think that's been a big shift in the culture of the community realizing we're here because of you, community. How can we help you?
Yeah. So another aspect of this that is really intriguing is related to public health. Mm-hmm. Traditionally, public health and health care have been largely separate entities in most communities around the country. And one of the important parts of the vision here was to see if we could somehow bring public health and healthcare together where they were working toward the same mission. Public health has created some fantastic programs, and they largely had difficulty getting those embedded in routine healthcare delivery. And so this was a challenge. And I wonder if each of you may describe in your communities how public health programs have been brought into play, how the public health people in the local district offices are part of your teams, and give some description of how that's occurred.
Sure. Well, again, this isn't something you can just start. We've had long-standing relationships with our district office for our local Department of Health. And then you just build on those relationships. So as you bring on new initiatives, we need their resources. And we've been used to working with them, and so we bring them in. We have a great Department of Health. With the WIC program, a lot of our clients are from WIC, and we've been able to send community health workers to the WIC clinics rather than the other way around. They're going to the WIC clinics anyway, and it works really well.
Yes, and some of the members from the Department of Public Health have been trained in self-management, so we team up to teach the classes together.
That's great. How about in Burlington?
Yeah, well, I think another good example, Craig, is tobacco. Vermont was lucky 10, 12 years ago to be part of the master settlement for tobacco money, and used that money to fund hospital-based cessation programs through the Department of Health. And in the last year and a half, we've moved that over to the Blueprint. We've moved it over to the community health teams. So recognizing that you didn't need two of anything, we needed one person or one group of people to help people quit smoking and make those decisions. And we've done very well in Vermont with tobacco cessation, and this was a very natural extension and the next step in the evolution of that, which happened within the context of the Blueprint, and it couldn't have happened otherwise.
We just ran a query actually using our registry function, looking at our Fletcher Allen primary care internal medicine practices, who has the highest percentage of smokers, and that's where we will actually target our initial tobacco cessation work and fresh start classes. So really bringing the two models together and seeing how best to make it, work for the patient is what it's what we really try to do.
Yeah, it's been exciting to see this, and the idea that tobacco cessation can now be as much of an embedded part of primary care, just like mental health counseling can be, and that's one of the visions in the model. So these are incredible examples that you've created in your communities. Let's go ahead and turn our attention to the next section of the video and how this program may be extended to other communities. What does it really take? What's the work that it takes to build the program in different types of settings? From the start, we've intended to make it so that the model could be generalizable, scalable, and sustainable.
The Blueprint for Health now operates in 14 health service areas throughout Vermont and serves more than half of the state's residents.
The real challenge was design principles and resources that would let these very different settings build the models that they need to help their patients and their citizens and their families. And that's really what we've seen flourish actually around the state in many different settings.
The original Blueprint pilot sites demonstrate how generalizable the Blueprint model has been. St. Johnsbury is a rural community in the northeast corner of Vermont, where there are fewer medical resources for a population that is generally older and more prone to chronic conditions than the rest of the state. In contrast, Burlington is an urban center with a dense population, a busy academic hospital, and many more practices to support. With a plan for 5 full-time equivalent community health team members for every 20,000 patients, the model has scaled to support the many practices in the Burlington area that have wanted to join.
This type of model uses payment reforms to put that type of holistic support in place for patients and families. The footprint of medical homes growing across the country is going to need similar types of strategies. And there really lies the opportunity for scalability beyond the borders of Vermont. And if we demonstrate that multidisciplinary teams can support practices in different settings, rural and urban, some version of that may be adaptable in other places in the country.
Vermont has the advantage of being small enough that the entire health system is organized at the state level.
The idea that we can make changes here whether that's legislative or even at the local level, is perhaps easier, if you will, because you can get your hands around it. I mean, the local level is a really small place. That being said, that doesn't mean we can't share our experiences and our knowledge with people in other parts of the country or other parts of the world, and learn also from people in other places.
North Carolina is a great example of that, where they have community-based teams supporting practices, a much larger state, and even though it's to date only a Medicaid initiative, it's working and it's helping them achieve these same type of goals. So there really are good signs that this is generalizable beyond the borders of Vermont.
Other health systems can learn from the challenges Vermont has faced in expanding the Blueprint model.
I think that behavior change on any level, whether that's an individual or a system behavior change, is a complex and difficult thing to achieve.
So when we first start talking to practices, they very often have absolutely no idea what we're talking about. It is a paradigm shift. So it's a long kind of courtship around really explaining it to them, helping them understand that we aren't imposing protocols or people on them, that this is a partnership.
The Blueprint team has also faced challenges getting the health IT systems from around the state to share information effectively.
It happens that the ability of electronic medical records to talk to a health information exchange and the complexities of writing interfaces for all of the Blueprint practices has been something that we are working on very hard to make happen.
Even with these challenges, the Blueprint team is seeing a pattern of success as the model spreads to new areas.
We can point to places like St. Johnsbury and Burlington where really they're on the other side of that now. I mean, they really feel like this was a lot of work, and it's still a lot of work, but it's absolutely worth it because we know we're doing a better job and we know people are receiving better care.
They're talking about solutions. They're talking about how they're going to help families as opposed to the problems and the barriers that were there in the beginning. And we're seeing that cultural and that social change in both the rural settings across Vermont and in the more urban settings in Vermont. And we're seeing it sprout up in the newer communities as well as the more established communities.
As the model spreads to more practices and covers more patients, the Blueprint team is working to ensure that the program is truly sustainable.
One of the primary and most important aspects for sustainability is to show that we can help control the growth in healthcare costs and that the investments in this healthcare model are offset. And the most likely offsets are going to be reductions in hospital admissions and emergency room visits.
People actually come to the ER less because they're in medical homes and they're getting the care they need. They actually call less, the phone rings less. We're saving lots of money by keeping people healthier.
In St. Johnsbury and in Burlington, and a couple of the practices that were involved since 2008, we can already demonstrate that the number of people who actually went to the emergency room and the number of hospital admissions have decreased in both places, and the patients who were part of those patient-centered medical homes.
Blueprint for Health is leading an innovative statewide transformation of health services. It provides a model for other communities to study as they consider their own reforms. As adoption continues to grow, Vermont will provide a wealth of information on how to effect comprehensive healthcare reform.
Welcome back. Let's talk more about how this program may be expanded to other areas. What are the key things that you've all learned that may be useful in programs in other settings? One of the things I frequently hear, and I think a lot of us do, is that, oh yeah, but that's Vermont. Somehow Vermont is different. Somehow this all can work in Vermont, but nowhere else. Well, let's talk about that a little bit. We know that there are initiatives all over the country right now that are being initiated by many different entities. In our case, we're lucky to have a state structure and leadership that's committed to doing this. But we see similar types of initiatives all around the country. And they may be initiated by states in some cases or hospitals. In some cases, people coming together to work differently in new accountable care organizations. And in some cases, it's insurers that are stimulating this type of change. But one of the common things we see, in one way, they all involve some version of a medical home better primary care and access to primary and preventive care. And then this seems to be a common underlying theme of teamness, wanting team-based services, interprofessional services. So let's address that. What are the key couple points that you all have learned in your programs about how to build this that may be useful in other settings? Let me start with the Burlington area and Fletcher Allen.
Sure. Well, I think one of the things we learned early on is there's no cookie cutter. You really need to go in and listen to what the practice's needs are, or that health system's needs are, and really look at what your team will be to meet their needs. It often is a multidisciplinary team. The disciplines may vary, however, as I suggested earlier, a psychiatry pilot. So really listening, sitting and listening, and even observing some of their, spending a day at the clinic and seeing what goes on and how you might be able to, help them improve access and improve care to their patients. I think that's key, the listening.
I think, too, with healthcare reform, and Craig, you mentioned accountable care organizations, I think there are ways that we need to evolve the healthcare in this country that this really can be a cornerstone for. Our primary care practices are all moving to a different way of approaching their delivery of clinical care on a daily basis. And it's much more team-oriented, much more making sure the right practitioner is providing the right service to the right patient at the right time, and not always relying on it being the doctor. Who is the right person? What's the most efficient way to get these patients through and support them and their needs? And then having the wonderful privilege of having the community health team as a practice extender is an extraordinary privilege that we sure don't want to lose. But I think there's other ways that you can even just improve your own processes and procedures by thinking more as a team and less as individual pockets of specialty.
And St. Johnsbury?
I think the relationship forming for us was one of the most important things, not just with the larger team, the community, but with our own team, working together and appreciating the value of working in a team and seeing the results that come for patients when we work together. So it's been a very rewarding, common sense way to deliver care to folks. People may call and their doctor's not available, but they'll ask for someone else on the team. So seeing that we're valued, seeing that patients are totally supported, is something that can be replicated any place.
And I think at the individual practice level, you just can't expect that this is going to happen. You have to get some training. I know our physicians talk about training they had in clinical microsystems and the IHI model for improvement. They can learn how to make some changes within their own practice. Mm-hmm. And then as far as bringing others in the community in, just don't forget about the patient and think about what the patient needs. And if the patient needs help from that organization, well, keep inviting that organization to the table. They're eventually going to show up or go to them. And then start forming your team that way and pulling more people in. We found that once you get going, people want to be at the table. They want to be part of this.
One of the things that was put in place early on was the ability for all of you and the clinicians and providers to have a chance to directly interact with other key stakeholders, particularly the insurers, and again, in our case, it's all our insurers in Vermont, as well as hospital leadership, as well as people in non-medical communities. And we worked hard to construct these environments. So not just teams at the practice level and the service, but beginning to organize teams at the administrative level and the leadership level. And we've seen that change over time as well, and I think that's one of the important things to highlight. I think that builds the buy-in and the engagement just as much at the level of who's paying for healthcare as it does at the ground level. And so again, teamness can play out in many different settings. There needs to be training, there needs to be support to make this type of change. Can we comment a little bit on that aspect of it? How have the coaches and practice facilitators helped in your communities? You want to start in St. Johnsbury?
Sure. Primary care is very, very, very busy. And it's really hard to find the time to make those changes and even think about what needs to be changed, even if they know things aren't working quite right. So having that facilitator, someone who knows the practice, can come in, sit down, what do you want to work on? What's important to you? And lead them through it and hold them accountable. They know they're going to show up again and ask them what they've been able to work on. it's made a huge difference, because that person does have the time, and they can do that little extra, be that extra set of eyes, set of hands to help them through.
And I think for the staff, it relieves the anxiety. It's a new world. They're treading new water, and they're very like, okay, what steps? And we have all overachievers, so they definitely want to go for the max. And the facilitator calms them down and tells them how that's not, let's just get you going here. Don't worry about going to the top. But of course they do. But that's been real helpful for them.
Well, to move from the old hierarchical approach is difficult. And if I don't feel I have a voice, even though people may tell me I do, until I experience that and see someone that I think is above me hierarchically listening to me and actually valuing what I'm saying, and now I feel safe in that. And sometimes that takes an external facilitation, because we're all busy being ourselves, and managing ourselves in that is often impossible.
I think we found with many of the smaller practices in the Burlington service area, a lot of the practices the physician, maybe his partner is his wife or his child or someone working in the practice with them, and they certainly have all their policies and procedures and they know what they are, but they're not written. And having the facilitator say, unless it's written down, it's not a policy according to NCQA or anybody else. And that was really something that was really, I think, very helpful for them to hear, because I hear a lot of the smaller practices say, we do things so much more efficiently now because we're all on the same page, because inevitably someone's going to be out sick and you're going to get a temp, or somebody's, making a change and you get someone new. So now they don't have to start from ground zero anymore. They really can point to the policy. Everybody knows they're on the same page. And that really has been the facilitators that have really helped make that happen and help people understand the value of that kind of work.
Yeah. So this all highlights the importance of the right investments, the right incentives. Let's finish up talking a little bit about some of the challenges that you've all had in building the programs in your community. Again, I commend the leadership and the vision that you've all put in place. But let's address what are some of the key challenges in order to build a program like this? Let's start with Burlington and Fletcher Allen.
Sure, I can speak to IT has been a real challenge. We're in 19 different clinics, upwards to 35 when we're finished, and we have right now 7 different electronic health records, none of which talk to one another. So that's a huge challenge. And how do we get our folks trained on different EHRs? That's how we communicate with providers and staff. So that's been a big challenge, as well as the whole health information exchange. So that's an area that I think is something I know everyone's continuing to work on, and don't have an answer yet, but that has been a challenge for us.
Certainly information technology, but also, and this is becoming less and less as the months pass, but doing this in the context of something that people had no idea of what it was. They hadn't done an internship or a residency in a hospital that had something similar. So we were having to explain what we were talking about from the very ground up, and with new relationships, you have to do two things. You have to build the relationship and the trust, and then you have to also work together in a complex activity that you don't know what the end point is, and that was very challenging. As this has matured, that has become less so.
One of our biggest challenges at the beginning was figuring out the referral process, because our model has no criteria. Anyone can be seen, any age, any income bracket, and they can be self-referred, or they can be referred from anyone in the community, an agency or a provider's office. But we did clinical microsystems and worked it out and found that really a fax referral works really easily. We provide everybody electronically, even with the fax sheet, and with the push of a button, the referral comes through. So it wasn't as challenging as we thought it was going to be.
Yeah, I think I'd have to say IT as well. I think Pam described it very well, but also we welcomed the idea of having these systems that could talk to each other, and it was somewhat frustrating when they didn't do that, because we know that there is the possibility that it's going to make communication and the flow of information better, which is only going to be better for the patients.
And then I also think, for me personally, the biggest challenge was just keeping up with people. As Pam says, we have a lot of overachievers, and I just felt like I have to keep up. I have to keep up with them. They come up with great ideas, and I've got to have the energy to help them see those ideas through.
Well, I can tell you from the Blueprint team perspective, we feel the same. It's been tough to keep up with all of you and the incredible job that you've done. Just to build a little bit off what you've said, the IT part of this is such a challenge, and it was one of the reasons that we began to work so hard on a central clinical registry for a couple reasons. In the end, if you get teams of people working together from different settings, how are they all going to share one health record? How are they going to know a patient and family goals? And you need to somewhere create an integrated health record, and that's such an important piece. One of the fun things of this has been watching the culture change in the communities, and now that the teams are working together, they're calling more and more for the IT. Where are those reports that we need? Where are the outreach and panel reports that we want so badly? So the call is there, and we have to work hard to respond to that and continue building out this exchange and the central registry. One other challenge I've seen that I think is an interesting one, and maybe it's not a challenge so much as it's just part of watching the natural history of things, and that's trainees, a workforce, coming in that know how to work as interprofessional teams. That certainly isn't how I was trained in traditional medicine, and we're watching the call for interprofessional education, for people really to work together, starting early on, not have social workers and medical residents so distant, and all the other examples we can think of. So I think interprofessional education is probably a challenge to keep up with the demand that is emerging around the country. Well, I think we're out of time for today. I really want to thank this panel for all the incredible information you've provided and all the hard work that you do to build this program. I want to thank our audience for being part of this and allowing us the time really to share these ideas with you, and to AHRQ also for the opportunity to do this. If you have any questions at all, please send them forward through the AHRQ Innovations Exchange. I think we'd all be happy to address them and answer them, and we'd also love your ideas and thoughts. Again, thank you all very much.
Thank you for joining us this afternoon. We have provided hyperlinks for more information on the Vermont Blueprint for Health, AHRQ's Prevention and Chronic Care Program, and the Linking Clinical Practices and Community Organizations to Improve Care page on the Healthcare Innovations Exchange.